Hello everyone, welcome to Medicoz Community. Our today's topic for discussion in radiology is chest X-ray signs in pulmonary embolism and pneumomediastinum. First, let us go through the topic pulmonary embolism. So, what is pulmonary embolism? As we all know, the pulmonary artery is obstructed with an embolus or a thrombus. That means there is no flow to the lung tissue and there will be decreased flow, that is oligemia will be present. So when we are suspecting a DVT, that we have to get a lower extremity ultrasound. If it is negative, then we have to go for a chest x-ray. If the chest x-ray is normal, it does not exclude a pulmonary embolism, so we have to go for a V by Q scan, that is ventilation perfusion scan, and depending whether if it is normal or high abnormal probability or low or intermediate probability, we have to go for a CT pulmonary angiogram. And if the chest x-ray is abnormal, we'll see about the signs which are very classical, and but always remember, if it is a normal chest x-ray, it does not exclude a pulmonary embolism. If the chest x-ray is abnormal, you have to go do a CT pulmonary angiogram. If it is positive, we'll go for treatment. If it is negative, depending upon the clinical signs and symptoms, we will go for additional testing or no treatment. So coming to the radiologic features, we divide it into acute pulmonary embolism and chronic pulmonary embolism. If it is acute, that means it has just arrived, then it isn't probably an embolus. So we'll be seeing it as a intraluminal filling defect. That means the contrast will be there on either side. The embolus will not take up contrast, so it will be seen as a filling defect, and there is tram tracking of contrast and abrupt cutoff of artery and missing vessels. All of these signs are in CT angiogram. Now let us see for the X-ray. So in an X-ray, what can we see? Because there is embolus here, that there can be a wedge-shaped opacity showing us an infarct, or there can be pulmonary opacities of any size and shape and they can be rarely lobar or segmental. They are just in one small space in one zone, and there are horizontal linear opacities bilaterally, most commonly seen in the lower zones, and pleural effusion, which is blood stained on aspiration, can be seen. As we have already discussed, there can directly go into infarct, or there is decreased flow, that is oligemia of the lung field can be seen. And because the embolus is here, it will cause enlargement of the pulmonary artery on that side. And because of all these changes, because there is oligemia and there can be infarcts, there will be elevation of the hemidiaphragm ipsilaterally wherever the embolus is there. So these are the classical signs. You have to know these signs. First, let us see about the wedge-shaped opacity I was talking about. The wedge-shaped opacity is seen peripherally as a radio dense structure here. It is called as Hampton's hump. There is oligemia. We can see there is vasculature on this side which is seen, but there is complete dark side on the right side. It is because of the oligemia. This is called as Westermarck sign. As I have already told you, there is enlargement of the descending pulmonary artery. This is the enlarged descending pulmonary artery, probably due to an embolus here, and there is tapering of the vessels distal to it. This is called the knuckle sign, and there is pleural effusion. So next, must know findings, I'm emphasizing on them again. The peripherally placed wedge-shaped dome opacity is due to the infarction of the lung tissue, and the oligemia, focal oligemia, that is decreased vascular marking due to a distal embolism. The increased right descending pulmonary artery, which looks like a sausage, that is the Pallas sign. The chronic pulmonary embolism features in a CT pulmonary angiogram are eccentric filling defects. These are muralized thrombus. That means it has been there since so much time. So it is seen as either as a web or a synechiae, or smooth cutoff will be seen beyond it, and almost there will be no flow in these vessels, so we'll not be seeing them in an angiogram. They will not take up contrast, so there are missing vessels also. And there is pulmonary arterial pressures are elevated because there is very little amount of lumen for the flow to take place, so the pressures will be elevated in these. To show you an axial contrast enhanced chest CT, So this is the luminal filling defect I was talking about. This is the complete filling of the contrast. This is the main pulmonary artery, and this is the right pulmonary artery, and this is the left pulmonary artery. This is the ascending aorta, this is the descending aorta, and this is the SVC. As we can also see, there is a embolus here in the artery. So that is about briefly the Hampton's hump, Fleschner's sign, and there is a melting sign, which is an infarct showing rapid clearing in contrast to pneumonic consolidation. And in we also see in the echocardiography, we will see McCollin's sign. What is McCollin's sign? It is hypokinesis of the right free wall. So the right free wall will be, so this is the interventricular septum. The right free wall will be decreased in motion, whereas the right ventricular apex will be normal in motion. So this is the McCollin sign. This is an indirect sign for pulmonary embolism. The definitive signs on X-ray are Westermarck sign, Pallas sign, and Fleschner sign, and Hampton's hump, that you have to remember. Next, coming to pneumomediastinum, pneumo means air, and it is seen in the mediastinum. That is, presence of extraluminal gas within the mediastinum is pneumomediastinum. Where does the air come from? Where is this gas originating from? Either it will come from the lungs, trachea, central bronchi, esophagus, and the peritoneal cavity, and it will track into the neck or into the abdomen. So the definitive signs for pneumomediastinum is the continuous diaphragm sign. Generally, there we will not be able to see this lucent area just below the heart and above the diaphragm, because there is central tendon insertion onto the diaphragm. But when there is air, we will be able to see the diaphragm. We'll be able to draw a line continuously from here to here. So that is the continuous diaphragm sign. It is seen continuously across the midline, and it is suggestive of free gas within the mediastinum. This is another example. Here we are able to see the air continues from the midline onto the opposite side in both these cases. Naclerio V sign, it is secondary due to esophageal rupture, and it depicts pneumomediastinum. The one end of the V is drawn by the left hemidiaphragm and the parietal pleura, the air between the parietal pleura and the left hemidiaphragm. The other one is from the, as you can see here, there is a lucent line here. It is the mediastinal line where which is showing air just outside it. That is where we are able to see the gas. So this is the inverted V sign, or the Naclerio V sign, which is definitive of pneumomediastinum. In pediatric population, if there is pneumomediastinum, the pressure builds up inside the mediastinum because of the gas, and it will push the thymus upwards and laterally, just like a Spinnaker sign, just like a Spinnaker sail sign. It is also called as thymic wing sign. The other indirect signs for pneumomediastinum are the tubular artery sign, because the arteries are also lined with gas. In case of pneumomediastinum, we will be able to see the arteries. The major branch of the aortic branches will be seen as tubular area surrounded by the gas on either side. This is another image showing the gas around the pulmonary artery and its main branches. This is called as ring around the artery sign. We should not confuse pneumomediastinum with the pneumopericardium. Pneumopericardium is the air between the visceral and parietal pleura, that is in the pericardial sac. In the pericardial sac, if there is air, it is called as pneumopericardium. If the air is outside this, that is mediastinum, and that is called as pneumomediastinum. So do not confuse pneumomediastinum with pneumopericardium. And the other features that they can be a pneumomediastinum is, in case of trauma, is subcutaneous emphysema. Here in this X-ray, we are able to see that the soft tissue is so ill-definedly seen, and this mottled appearance of the soft tissue. This is nothing but subcutaneous emphysema. So on the axial CT section, this is the subcutaneous plane, this is the skin, and this is the subcutaneous plane, this is the muscular plane. And in the subcutaneous plane, we are able to see the air within that. There is subcutaneous emphysema. In most of the cases of subcutaneous emphysema, we will also see a pneumomediastinum. So we should be careful and look at that and not miss the finding. So this is about pneumomediastinum. Thank you.